Hey, everybody, welcome to this episode of The Compliance Guy. It is Monday, the 19th of June in 2023, and that means it is time for a Monday Coding and Compliance Roundtable. Today, we have almost the entire crew. One is missing, but, we hope everything's all right with her. So today, we've got Christine Hall, Paul Spencer, Terry Fletcher, Scott Kraft, and I think we have a pretty dynamic show that's set up for y'all. We're excited to have you with us, and we look forward to your questions, comments, concerns. So I want to start with Paul Spencer first. So, Paul, let me go ahead and get you into the hot seat here. Um, you shared with all of us a situation that is becoming all too familiar, and that situation is ransomware attacks. These cyber terrorist organizations getting access getting access through a firewall or through a VPN or some other mechanism. Sometimes it's not through a direct point to point access, but they'll use a third party vendor to circumvent. They'll swipe the legitimate credentials for logons of people in the organization. So when the IT folks are monitoring and they see Scott Kraft or Terry Fletcher or Christine Hall or Sean Weiss are logging in, they don't pay much attention to it because it's us, it's our credentials. But by turning away from that, they might miss a traffic report where it spikes because an exponential number of charts are being taken out of the system at a rapid rate. And I'll equate this to one of our clients in just a few minutes. But because of this, these ransomware attacks, it's putting significant financial strain and burdens of all sorts on these different facilities. So, without me taking any thunder away from what you're going to talk about, let me turn it over to you and you kind of paint the picture for our folks.
Well, thank you, Sean. So, recently, a hospital about 60 miles southwest of Chicago, in a small town called Spring Valley, Illinois, population roughly 5,600 people, announced that they were going to close their critical access hospital in town. Now, they mentioned a number of factors. They also mentioned COVID-19, and they also mentioned short staffing. But if you're in the critical access hospital, you know for certain that short staffing is kind of a matter of course, that narrow margins are a matter of course, and you tend to get some of the best hospital-based billing teams in critical access hospital just because they know that they're up against the wall as far as finances go. Well, they were hit with a ransomware attack that was so profound that they couldn't get their systems up and running. They were on handwritten notes for a while, attempting as best they could to try and keep systems running, but they just decided that the better course of action was to close the hospital completely. Now, what this means for people in that area is that they now have one less critical access hospital for dozens of miles to treat acute medical conditions, such as strokes, such as heart attacks, such as automobile accidents that might happen in that area. So I there's a part of me that can't believe that we're still talking about this in 2023, understanding that hackers are extremely sophisticated. No, I don't think that anybody is falling for the Nigerian prince anymore, but we certainly have uh, many more sophisticated ways for ransomware to be downloaded into your systems. An overwhelming majority come through email. I know that I can speak for Sean and Scott for our IT department, where if suspicious activity starts going through our system, even though we're not particularly a large organization, suddenly our IT guy is, rattling the temple bells and saying, "Hey, we've got if it looks like a subject line from somebody in house is coming into your email, and you don't recognize it, it's best to delete it." And usually you get some kind of warning internally that an email is coming. So uh, understand that it's 2023. This shouldn't be happening. But in a place like Spring Valley, Illinois, your IT infrastructure is only as strong as the weakest link in your employee chain who's opening up an email in your company email system. It's always been that way. And it could be accidental, it could be any number of factors. But the faster you realize that mistake has been made, the faster you might be able to prevent this. But uh, it's the usual suspects, and I'm not talking about Gabriel Byrne or Kevin Spacey. I'm talking about Russia, China, North Korea, et al., who love to start this type of thing and try to infect our systems. And at this point, now you have a healthcare desert in Spring Valley, Illinois, where 2 weeks ago you had a hospital. And that becomes an exponential problem, not only for that town of 5,600, but all the other small towns that surround it.
Yeah, that's devastating. And I will say this, and then I'll go to the roundtable. Um, Look, there there's no doubt that we live in a new era. There are bad actors that are out there. There are people that are looking to harm corporations, health systems, universities. We have in our organization, we support the compliance efforts, the auditing, the coding, billing, education of several university medical programs, GMEs, and such. We've received notification from some of our clients that they were hacked. Um, their medical records were being held hostage. Of course, these large institutions have the money to be able to pay, or they get the FBI involved very quickly and they try to shut it down. One of my clients, and you've heard me tell this story in the past, one of my clients was hit by the Dark Overlord, which is a um, pretty profound cyber terrorist organization. They accessed my client's medical records via a third party medical record retrieval company that didn't have at the time, didn't have the protections in place that should have been there. And as a result, they got the credentials of some of our folks. They got into the system. And before anybody in the IT department recognized what happened through the traffic reports, they extracted more than 240,000 patient medical records and held it hostage. It led to OCR putting an initial demand against our client for over $16 million, a 5-year resolution agreement, which obviously the good news for our client was we were able to negotiate all of that down to more reasonable numbers, but still 1.5 million is a huge number. 2 years on a resolution agreement is a long time to be monitored by the Office of Civil Rights. And what I will tell you, folks, they are truly the police department now for all things HIPAA. They carry a big stick and they walk softly, but when they whack you, you'll feel it. So let me go around the table, and who wants to jump in first? Don't everybody
I'll
jump
jump in.
for
I think obviously when I think about compliance in our podcast, we're really about trying to bring solutions. And the reality is, Paul had made a comment about, we don't see the Nigerian prince anymore necessarily, but what that does mean is that a lot of these efforts are becoming more and more sophisticated. People are more apt to fall for them. They are modeling things that may look like part of your ordinary course of business. It's unrelated to healthcare, but I mean, there was something that happened out here where I live a couple of years ago, and I've heard about it in other places that was very chilling, where they had basically said that mortgage bankers and lenders are so infected by ransomware that most people, when they are going through a buy transaction, will get some sort of fake email to initiate the wire transfer for the down payment or something like that, where you're basically sending 5 figures of your down payment off into like the dark web somewhere. And so these are very sophisticated efforts. I don't think people should be reading their personal emails on a company device. If they are doing it, they certainly shouldn't be clicking on anything within them, no matter how safe you think it is. People shouldn't be downloading things onto their work devices without any sort of IT authorization. I know, Paul had talked about Sean and I and doctors management. We are not allowed to do that, right? Like if I try to download something, I get like a blocker where I have to call our IT department to do that. Like you have to be very vigilant because we all come from different places, and I will freely admit sometimes I'm not the most technically savvy person in the world. I sometimes say it's a miracle I can get the computer on every day. But in some respects, I overcorrect on that. Like I don't click on anything, right? Like I don't share anything. I don't click on anything. I don't do anything that will imperil my equipment. And I think we're just going to see more of these stories. And I can only imagine because a lot of these ransomware transactions are private. Who knows how many of these are taking place every day, and we're never hearing about them, right? And to Sean's point, larger organizations can survive, smaller ones can't, right? So if this happens to, a 5, 6, 7 doctor physician practice, what's going to be the outcome of that? The practice is probably going to have to sell to stay in business, basically.
Yeah.
And let me just kind of go top on that since you're going down the line here. For those remote workers out there that are using their home personal computers to access patient charts and access files and things like that, and then you take a break during the day and you get on Facebook, you get on your social media account, that is basically inviting the risk for this to happen, especially if you don't have firewalls, if you don't have safeguards. And I recently had a couple of clients that said we're having to pay $18,000 because one of our employees decided to shop on their lunch hour at their home address, a computer that, of course, since the pandemic, nobody really vets what people are working off of. And basically, they then went on Venmo and they went through the Cash App and they got the ransomware situation, the cyber attack. And then another one had it because they clicked on, to Sean's point and to Scott's point, they clicked on something to purchase, so they went shopping at lunch. And it's not just the entities. So be careful with just thinking it's at your office. It's the remote workers as well. And if you're a practice out there that has remote workers, you need to start doing some compliance oversight. You need to figure out, are they using their home computer, their home laptop, or did you issue them a work computer that has all the firewalls that, for example, Sean and doctors management people have. So, and then I know Christine has, we all have these secured computers, but does everybody else? I'm thinking a good percentage, they do not. And I think the other thing they'll probably find out is when they go to the remote worker's home that they're probably doing things at their kitchen counter, not in a locked office where you can't see anything. So, we're past the pandemic. It's time to protect.
Well, and just to piggyback on that really quick, one of the things that I would say to my clients or our clients all the time was you should not be allowing people to do work on their own equipment. It just supply people with the tools that they need. It's an investment that gives you much more control over these types of instances than if you have people just kind of grabbing their own laptop and then maybe they finish work for the day and their kid gets on it and plays games or something. There's just a lot going on there, and I don't think it makes any sense to have people that you're putting in position to do remote work, but they're using their own equipment. Like I just think the risk far outweighs whatever nominal savings you're going to get from not supplying that person with a device.
I couldn't agree more. And another thing that I've done in my own organization is, because I have a home office, I have a separate IP address for business, and I only use that IP when I'm working. I have my firewalls in place. And that way, like you said, if someone comes in and starts playing video games, they're on their own separate IP. It has nothing that's going to cross over into work. So I know that during the public health emergency, we blew the barn doors open and we just needed to function. Well, that was only in a temporary time period, 3-6 months at best, but we should have always been looking towards what is the best way to protect ourselves, even during the public health emergency. But now that it is over, there's absolutely zero excuse why we cannot do a better job.
So, and I agree with you 100%. So one of the things that I would tell, that I tell folks all the time is, listen, you've got to perform your security risk assessments. You've got to do your SRAs. If you're not sure of what you're doing or how to do it, there are people out there who can assist you. I did a podcast with somebody who I consider to be the godfather of HIPAA. His name is Elliot Golding, and if you get a chance, go search out on. You could go to Google, you could go to Spotify, wherever you listen to your podcasts, and look for the episode of Elliot Golding and HIPAA, and he literally breaks it down in layman terms. He really goes through it in spectacular fashion. But he is without a doubt the person that should be in your inner circle of trust as your go-to for all things related to HIPAA. All right. So let's talk about another critical topic. And that is physicians' reliance or non-physician practitioners' reliance on electronic medical records, and them believing that just because a template has been created for them and a plug and play, that everything on that template is what it should be. And that's the gospel. But as auditors, we know that's not the case. So let me start with Christine, because I know you kind of you had some bones to pick about this. So
I got my
let's
hair
start there.
ruffled on this one. I spend a lot of time auditing, and I just can't believe that providers have just given up. Okay, maybe that's a strong word, but it looks like from the templated perspective that they're just given up on it. I don't even look at review of systems or the physical exam anymore, because everything is unremarkable. They just go down and click all of the boxes, whether they're relevant or not. We see this. It's true. Terry and I, we audit telehealth, and we see these full system exams that are performed via telehealth. Impossible, by the way, to do that full head to toe exam via telehealth. It almost seems like, though, that they've given up. I'm just not seeing it. And the argument is that I paid good money for this electronic medical record, and that should support anything from a payment perspective. They don't seem to understand that it is just a tool that we're using, that the templates, we modify them to serve the needs of that provider, to cover continuity of care, to cover that legal record, and to support what they did from a payment perspective. So I feel like I'm constantly fighting to explain, don't give up. Do go back to the SOAP note, maybe, think about it from that perspective. What would you have done if this was just your typical SOAP note there? Terry, I know that you've struggled with this too.
Well, and I'm also having something that I'm frustrated with, and this is because, again, going back to the EMR, the EHR, the doctors are assuming, and you know what happens when you assume? They're assuming that not only is that EMR gospel, but they think it's also being updated. And since we've had the 2021 rules, they haven't been updated. Everybody is still using the 97 or 95 guidelines. And my concern with that is, like Christine said, a lot of these exam templates don't make sense. I've got patients that are coming in complaining of one thing in the history of present illness, and then I don't see it anywhere in the exam. So they say that they've had this lesion on the outer portion of the left breast, and then you go and look at the exam, and nowhere does it talk about this lesion. And then in the assessment and plan, they're doing some kind of lesion removal. I'm like, oh, how did you know that if you didn't, do some kind of exam? And then I get the provider saying, well, I didn't have to do an exam anymore. Remember, it says I don't have to do a history exam. I'm like, oh my gosh, did anybody not read the rules? You still have to have a problem pertinent, medically necessary history and exam. Otherwise, it doesn't make sense. So my concern is also the doctors hire us and the providers hire us, the hospitals hire us to give them information so I thought that they're compliant, peace of mind, understanding what, or that they're supporting what they send. But I'm finding that it's now such a combative relationship and a struggle. They don't want to believe your results unless you're telling them, look what I found to make you more money. And it's just like, we do find that on occasion, but our role is to make sure that you are compliant, that what you're submitting to a payer is supportive of what you've documented, and that you're using the correct guidelines and rules for today's encounter, not for 2019's encounter. And so there's some frustration on a lot of audits right now, because I just don't see it being a partnership, relationship from an auditing perspective. And the last thing I'll say before I'll send it over to somebody else is that make sure that education is part of your audits. I'm finding that audits, just for the sake of having the results without any corrective action education, does nothing, does absolutely nothing. I've actually had to put it now in my auditing that if you're going to hire me, I want to see, you have to rehire me back in 6 months to make sure you did what I recommended, especially if I find blips that are borderline, I'm not going to use the F word, but are borderline inappropriate for how you build it. So, Scott, I'm sure you see all kinds of things like this.
Well, hold on one second before you go, Scott. I want to put up Pam's comment, because I think it's a great comment, and I'm with her 100%. The EMR vendors have a part to play in this. The layout of the note needs to be updated to use 21 terminology. How many providers right now, when you're looking at their notes, are still the EMR, templates are based on 95 and 97 documentation guidelines?
The problem is, though, it's not in the contract. They don't have to do it. We'd like them to do it, but there's no contract saying they have to.
Yeah.
Or there's an additional fee to update those templates, and providers just don't want to absorb that cost.
Well, I'll address that in a minute, but Scott, go on.
I'm sort of two minds on that. So I did this audit last week, and it was an audit where the assessment and plan was like probably among the most templated things I've ever seen, to the point where it basically had a list of diagnoses, and then there would be a comment like each diagnosis was addressed based on its severity, and any medications were refilled as appropriate, right? And I'm like, okay, so I don't know what, if anything, was refilled. I don't know what this person's on. And I do think EMR templates need to be updated to some extent. But another thing I see that is troubling with respect to macros is, I always felt the nice thing about the move to these new guidelines was it took us a little bit closer to like an old soap note, right? Like, just tell me what's going on with this person. Be granular in the history, be granular through the exam. The nice thing is, you're an ENT, you no longer have to do like a head to toe exam in order to make sure you get like your level 4 or whatever. You can just be very upfront and specific about what's going on. But what I end up seeing in these macro statements is I'll see the provider essentially like aping the terminology of the guidelines and saying, well, this is a new diagnosis with uncertain prognosis, but it really doesn't match the way the guidelines define that terminology. And it's, we're coming into this world that I see sometimes where I think notes are becoming over macrotized, and the providers are basically like giving us these very generalized statements like, hypertension stable refill, hyperlipidemia stable refill. I don't really have a lot of level detail about it. I don't really have any great, history that takes me through it. And, it ends up being something that's like the bare minimum to qualify for a code, but it ends up being sprinkled in with language that really is templated in a way that is designed to deliver a code level. So I see that a lot around things like surgical discussions and injections, where I was having a conversation with a client earlier today where sometimes I'll read a note and it's like the provider is pitching injections for the first time for like a knee or a shoulder injury. But if you go back through the record, like every 3-4 months, it's kind of the same discussion. Like, well, we could try an injection. And if I'm only looking at one note, I'm saying to myself, well, this looks like a decision to do a minor procedure, but it really isn't, right? And so I think, I don't know how to solve some of that, but it's getting back to the roots of compliance, the roots of understanding like what risks you're taking as the rendering when you're doing some of these things. And I think, to Terry's point, engagement and education. I have some clients for which I do the education. I have some clients for which they want to do the education internally and they just want like our findings. I tend to find that when I'm doing recurrent audits, the rate of success goes up more when I do the education. And I think that's less a commentary on my education skills, but more a comment on the fact that I don't work there, right? Like the doctor doesn't sign my paycheck. I don't have to worry about, causing some sort of dissent in the ranks. I don't have to worry about, being afraid to have those conversations. And it's, I think this is a very important discussion that's got a lot of layer and nuance to it because I thought documentation would get better with the move to these guidelines. And I think in some ways it's getting worse.
I agree with you, and I think so we think the documentation has gotten worse, right? And I'm sure auditors at the insurance companies, at the government, at CMS, they probably all agree as well. But the doctors probably love it, or the qualified healthcare professionals probably love it because they look at it and they say, I only have to provide what I believe is a medically appropriate history and exam. And since nobody has defined what that is, I can basically put down whatever I want it to be. Terry, what are your thoughts here?
Well, I agree with you since I'm doing probably 50% audits for payers and 50% for providers. I'm finding that what payers are looking at and what the provider audits are looking at are completely different. And I'm trying to incorporate my knowledge from what the payers are looking at and explain to my clients, look, they're looking to make sure that you are falling in within the guidelines of the current AMA and that it is medically necessary. And I know, Sean, you and I are having a conversation tomorrow about that. But the one thing that I think is lost too is internal versus external audits. And I know we have a lot of listeners. I know Pam, and I know Sonia. I know that we have just a lot of people that are listening to this that are auditors as well and do a great job internally. But we do have some internal auditors that are, as Scott said, you work for your provider. You don't want to ruffle feathers. You're concerned about if you bring up any negative information that, not just could you be canned, that, it's not going to be well received and it could basically reflect badly on you. We don't have a stake in that. You hire us basically as a third party auditor to say, look, this is what you billed, or if it's retrospective, or this is what you're going to bill prospective, and these are the rules. And did you mesh? Did you support it? And we don't really have a stake in if somebody doesn't like what we say. We just say it like it is. And a lot of audits are positive. We don't get us wrong. We do have some positivity out there with a lot of audits, but more and more we are finding that even the practices that internally audit, it's not always, it's more to show the physician that they can placate what they want instead of really tell them the reality of what it is. And I have several clients that when I see them internally audit, they say, can you take a look at this? Because we just got a payer audit and our internal auditors said this was, A-okay. And I look at it and I'm like, well, you guys actually failed the audit of the 30 records you sent me by 80%. And it's just like, how did we fail that? And I just said, well, first of all, you don't have a complaint and you're trying to bill something that isn't there. Secondly, you're kind of fishing for services. You're not really saying that the patient has something. And third, your history and exams, even though again we don't use it to level, are not consistent with what the patient's presenting for. And when we see those inconsistencies, you're going to get a payer. I'll just put it out there. United Healthcare does this. If the patient complains of something in the history and there is not an exam to show that you address that complaint, they won't even read your medical decision making. They'll just negate the record. They'll say, well, obviously this isn't accurate. To Christine's point, you say you palpated a mass in somebody's neck for, a thyroid situation, and this is a telehealth visit. Somebody's going to say, whoa, 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 how'd you do that? That's magic. So, I think to all of our points, it has to make it make sense. Who said that? To make it make sense, and
Well,
sometimes it doesn't.
and I think the important part about the education is what is the right solution to whatever the problem is. Because I've seen instances where we've done recurrent audits or there's been some internal education, and you can almost like walk through the hypothetical, right? So if the internal education is, well, the way the guidelines work is 3 lab orders is moderate data and 2 lab orders is low. So you only have 2 lab orders. So you only get low and it's only 99213. Then when you get the follow-up audit, suddenly there's like some other lab in there for all these people, right? And it's, how many inpatient notes do I see where there's these template statements about, I reviewed all the documentation, that data dump of X-rays and EKGs and all this other stuff that's going on, and it really has no pertinence to what that provider is managing, and I think there's gonna be. I feel like these guidelines are great, but in some ways they went too far towards enabling these types of things because of some of the vagaries that we've talked about in this conversation. And at some point, if the bell curve data comes out, if the payer data comes out and shows, well, all of a sudden we've got all these level 5s and level 4s, there's going to be some sort of course correction to this stuff. And I mean, I think those are our concerns. I think Terry said it. We see a lot of great notes. I mean, I do a lot of audits where the providers do a great job with the documentation and understanding, but one of the interesting paradoxes of the guidelines sometimes, and this was probably more the case for 95 and 97, but I see it now, is I would find myself penalizing the providers who documented just more naturally because inevitably they would miss something versus the provider who had a giant template of statements and macros and everything else. And in reality, these guidelines should be closer to the world of less macros, less template, just tell me what you're like doing. Tell me what you're ordering, tell me what the history is. I mean, that's the way I think these guidelines were intended to operate. But between, EMRs and things that providers are doing, I think we're just finding circumstances where, data's driving the note, things are coming up in documentation that doesn't make a lot of sense.
I think it goes even deeper than that. I think, it's, why is the patient here today? Because in a number of instances, all you see is active problems. And, we're not seeing real input into those active problems and, and where they stand. I mean, start from the basics. It's like, go to the beginning of the encounter. Why is this person even here today? Because we're seeing notes that are incredibly similar to the last notes that we had for this patient the last time they were there.
Yeah, and to that point, I noticed that we had some comments in the chat. Kimberly mentioned for those providers that do not understand the return on investment of training their workforce, education equals cost of providing quality care. One of the things that I've noticed that when people quit their job or you lose staff, and we have a staffing shortage right now, one of the biggest complaints is they feel that they weren't trained. They were set up for failure. They were thrown into a job that they just really weren't equipped for without training. And I'm finding that a lot of the providers just, bless their heart, they're trying to, I think for the most part, do what's right, get trained correctly. You're going to have some providers that really just don't want to mess with documentation, even though we need them to. But it's tough because I think that everyone is technically trying, but there's just the lack of education is causing all kinds of problems. And Christine.
So just quickly, you hit it on the head, Terry. I'm about to go out to Texas and do an education to the medical assistants on documenting the HPI in this new world. Let's think about it. They don't really need all of those elements or the ROS. And that's what I'm seeing now is that patient came in for follow-up, refill meds. There's no HPI. There's no ROS, or the ROS is just unremarkable everything. But I think we need to invest in our support staff as well. If that support staff is going in and prepping the chart for the provider, as they are allowed to do since 2018, is to go in and get that history component, make it matter. Have them find out, what does the provider need to know about these conditions? How has it been? What is we reporting? That helps support whether it's stable, unstable. And I'm sure that not only from a payment perspective, but that continuity of care, that would be the kind of information that a provider would need and that could make a difference. So like you said, Terry, maybe it's that we don't have that scope of work set in place to really have the assistants do a good job prepping those charts or providing that information to begin with.
Well, and I think as auditors and educators, I think one thing that I know we're running up against for all of us that are educators too, is that we don't have guidelines. We're having to use best practices. Now that AMA has kind of blown up what an exam and what a history is, we're having to come back to make it make sense, make a reality. Even the CPT book took out the fact that you need a chief complaint. But then when you look at the reality of an E&M service to get to the medical decision making, the what makes sense is the patient's coming in for a complaint, right? So what is that? What are you addressing instead of, like Christine said, refills? Well, refills alone is not anything. That's part of the history. You have to examine why the patient has those chronic conditions. What are the status of those conditions? And Paul made a point not too long ago, I think on one of our episodes, and I love the point. He went back to the Marshfield Clinic. He said, look, remember the old rules that basically said why we're doing something? Is it the interpretation of something we're looking at? Is it a film? Is it a specimen? I love that. I mean, we're having to go back to old school. Remember, you always miss what you used to have. And that's the only way to actually kind of make it make sense, that we have these history and exams that say absolutely zero or say too much, and they're not consistent with what the outcome is of that encounter. So we have these, textbook medical decision making elements, but we don't have what led to that. And that's where it's becoming such an issue right now, because we're having to rely on best practices, and everybody's just trying to say, well, it doesn't say I have to have that, or technically I don't have to do that. And oh my gosh, for Sean's the legal guy here that deals with all the backlash of when you don't have things correct. And I know Paul too, and I think Sean or Scott gets in on that as well. But what's hard for me is, why do you always want to play defense? Why do you always want to basically say, well, I'm technically covered? Why wouldn't you want to say, you want to look at my charts? Here they are. We do a good job because we make sure it makes sense.
Well,
Right.
and I,
A provider that spent $100,000 in a legal defense, but at the end of the day, they won.
Yeah, right.
Go
What
ahead,
did you
Scott.
win?
and I think some of this also, the last point I'll make on this, and I think this is a struggle for internal people more than us, is these changes around medically appropriate sort of widen the gap or create a chasm between, you know, me as a non-clinician, or an internal auditor or coder as a non-clinician, and the provider. Because when we have medically appropriate, like who am I to go to like a neurologist and say like, well, doc, you didn't do an examination of, the extremities, and that doesn't make any sense to me, right? And under the old guidelines, at the very least, it was like, I may not have many skills, but I can count to 8 or count to like 10 or whatever that is. And I think it just adds to that complexity, right? And that, I think, makes it harder to have those conversations, because the provider, I think it's been a long-standing thing in our industry where providers say to people, well, you're not a doctor, how do you know anything about anything, right? And some of these changes around medically appropriate did not help.
Well, remember what it says in ICD-10 now. It started this in, I think, 2021. Correct me if I'm wrong, Christine. But it says you can't make these decisions without your coders. They finally said the coders and the providers have to do the work together. And remember what an audit does. Whether it's an internal audit or external audit, this isn't meant to discredit anyone's work. That's not my goal anyway. It's to, really serve as a chance to improve as a team, understand what can support, and to be proactive so that you don't get a formal audit later on. So Just everyone has to work together on this, and I'm not seeing this being an issue.
Yeah.
Yep. Just we're in 2023 now. We're 2.5 years into the new office guidelines and 6 months into the hospital guidelines, and that's something of a different animal. But realistically, we should be seeing at this point an end to documentation that contradicts itself, whether it is a history of present illness where the patient states that they also complain of shortness of breath, and then we go into a review of systems template, which is not needed anymore, and it says deny shortness of breath. I mean, we should be beyond this, and we're still seeing it. And I understand that EMR companies are going to charge you a fortune for putting these things together. But at the end of the day, you need an EMR champion inside your practice, and it should be somebody who's a clinical person to tell you, hey, it's time to fix this. We're 2.5 years in, I mean, 2.5 years in the, 2.5 years ago, we didn't have Chat GPT. I mean, 8 months ago, we didn't have Chat GPT. The world is moving. The world is changing. You have to keep up.
Yeah, and one thing I would say too is just appreciate that it's not easy to do these things, right? Like one of the last points I'll make on this is time, right? Like how many times I've said the sort of joke on this podcast before. In 2021, every patient got 5 more minutes on their level 4s, right? Like suddenly everybody that used to get 25 minutes started to get 30 minutes. But how many times, like I've gone through some of these things with clients where I've asked them about time and they just sort of say, well, if the provider documents it, we just accept it.
Yeah.
And then you look at the note and you're like, well, how in the heck did this take 30 minutes, right? This is like a 12-year-old kid with a sore throat, right? Like it's just, and I just, you have to be thoughtful about the necessity of the work process, because especially I'm looking at these audits and every patient's 30 minutes, right? It's like, it's never 25, it's never 33. It's like always exactly 30 minutes, encapsulating review of records, right?
So I want to add something to this, right? Because I, I don't know. I mean, I know what work our in-house team, Scott and Paul, do, and I know they don't sit on the stand. But I think, Terry, you've been deposed, and Christine, you've gone through it. I will tell you from all the cases, and I probably have 40, somewhere between 40 and 50 cases that I've been a part of, just in the last 5-6 years. Every single one of those cases, whether it's a civil or it's a criminal case, they will go to the patients and they will ask the patients, how long was your visit with your doctor? And when the patients say to them, he was in and out, or she was in and out before I could even ask a question. My mother who's 82 years old, she has every condition known to Dr. Google. Every day it is a different, Sean, I have X, Y, and Z. And I'm like, who told you that? Well, I Googled it. Well, thank you to Dr. Google. I appreciate
Your mom know my mom?
Yeah, probably. So, what I will tell you is, and the number one complaint I get from her, because she lives in Florida, she lives in Boca Raton, Florida, where all the Medicare beneficiaries either live full time or they migrate to as snowbirds. Every single one of them says, I saw my doctor for 2 seconds. My doctor was in and out. They didn't even examine me. Folks, I am telling you, do not simply sit back and accept what a provider puts down as time. Look at their schedules, because I'm going to tell you, while we have an ability to disprove the medically impossible day when it comes to practices that use PAs and nurse practitioners to get to the certain number of RVUs, which makes the government kind of go, wait a minute, I will also tell you what becomes impossible to defend is every single visit can't be 30 minutes. It's statistically improbable, okay? It 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 just can't happen. So, your job as a coder, okay? Now I'm gonna try to get a little technical here, and ladies and gents, you guys help me if I step off the cliff the wrong way. As a coder, your job is to review the medical documentation created by a provider prior to the submission of the claim to ensure that they dotted the I's and crossed the T's and that the CPT, ICD, and HCPCS code that were selected are substantiated by the documentation. In other words, your job is to abstract information to make sure that the claims are kosher before they go out. As an auditor, your job is, if you're doing prospective audits, the same thing, right? As a coder, prospectively review the claims to ensure that the documentation substantiates the services being billed or the level of services being billed. On a retrospective, a looking back process, your job is to take a look at what was billed, what was documented, what was paid and or denied or requested as additional documentation to support what was billed, and to make a determination as to whether or not it was supported. Whether you're a coder or you are a biller, at the end of the day, your primary responsibility is to be an educator of the uninitiated, which in most cases are going to be the clinicians. And your job is to educate them as to what the coding, billing, and documentation guidelines are so that they can submit clean claims. And on the back end, to Terry's point, when somebody says, we're going to take a closer peek at what it is that y'all have done, that's when you say, yeah, man.
Well, I
Yeah,
think
I
that
mean,
that's not how workflows work, though, Sean. I think
I get
it's
it, Terry, and you're right. I'm
yeah,
with you. Go ahead.
yeah. Well, I, I can't really say that that's a coder's job because I think that coders right now are putting in codes. They're some of them are on benchmarks that productivity, they have numbers that they have to reach, and I don't think they're in a position to look at every single document that goes across that, especially high volume E&Ms. I think that if they see a pattern of probably high codes for a physician or a flatline coding physician, just remember, people, that's just as bad, where that means they only code one code of service, and that's usually a level 4. It's amazing how they love that level 4. But if you see a provider that has more of a lightning bolt, you know, for their for their profile, instead of really looking at a really good, level 2s, 3s, 4s, and 5s, then I think that's a position that they either have to find their CDI specialist that's actually the auditor in the practice, or if there's no person that audits in the practice, then yes, I think the certified coders need to look at that. But you're going to have some practices that don't have certified personnel that basically have, and this isn't to say anything bad about anybody, it's just that you have people that don't have the knowledge on how to extrapolate codes from a record. And I think that's where there tends to be some issues where you're relying on the physicians in their EMR, where some of those EMRs have that auto populate. And then it just, like I think Scott said, just brings up, or Paul said, brings up a code, and that's what gets submitted. And until somebody questions that, there's really nobody auditing or checking it. So when you have, a strange bell curve, then that's something to take a look at. Again, when you have something suspect, that's a look at. But to expect coders to look at every single record, I just don't think that's reasonable. And I think that's part of the reason why we're here, is because it's a problem right now.
Go ahead, Scott. You had something that you were going to say.
Yeah, I was going to say a couple things. I think one, to build on to Terry's point, I think because we know that these activities can't occur in that way, it's really up to organizations to create the tent poles or the parameters under which providers operate. I mean, particularly if you're in a world where the provider's employed. I mean, to go back to this time thing, it's sort of like the tail wagging the dog, right? We just say, well, if the provider said it's 30 minutes, it's 30 minutes. I mean, if the insurance company calls the patient and says, how much time did you have with the doctor? And the patient says 7 minutes, right? That's an awful lot of records reviews and other things. And I will mirror what everybody else said. I think the only time I've ever spent 30 minutes with a doctor in my life is when I'm doing like provider education calls, like in this job, right? Like I mean, I had like an emergency lung surgery and I didn't have 30 minutes with the doctor, I don't think. So, it is really important to be thoughtful about, what you're doing and how you're doing it, just in terms of, I mean, there's things that I've had people say to me in my job where I just, I'm like, please don't ever repeat that to me or anybody else again, where they say something like, well, the reason I think I'm good with a 4 on this one is because they got me on some other one where I was stuck with a level 3. I'm like, well, it doesn't work that way, right? It doesn't, this is not a gotcha game or to get everything even. And, compliance, like this podcast, the things we talk about, like compliance is proactivity. It's not like reactivity, even as we are often being reactive in our work to the things that people put in front of us. My job, I always think, is I'm trying to move the needle towards, you know, let's react to the things that are going around us, to let's create a culture, a pattern, whatever you want to say, where compliance is sort of baked into our DNA, where we're not trying to figure out how to get everything to be a level 4 or a level 5, and we're just saying, like, these are the patients in front of us, these are the rules, this is the documentation, and this is where it lands, right? And if you do that, like, you're far more likely to land in a defendable documentation pattern, so long as you understand what all the rules are.
I think what's tough is that there's a problem with definitions. I mean, do you have providers? I know I do,
Oh
that
yeah.
think a complex patient is a level 5. No,
Yeah.
you have a patient that's multiple problems going on, and you're putting down stable, stable, stable for today's encounter. I swear Christine's never going to get that out of my head. For today's encounter, that is a stable problem, or 20 problems. That's not a high risk patient per se. Now they
Yeah, I
say,
mean,
well, I can get up to 40 minutes. So is that okay? I'm like, oh my gosh. Like you said, now everybody's
the
40
idea
minutes.
is not if you could get there, right?
I
Like, certainly there
know,
are
right.
patients who have a number of conditions where it requires more time potentially. And these are some of the reasons why time exists. But yeah, complexity, I still say it's some under these guidelines, but I used to say under the old guidelines, you could get from a 3 to a 4 on volume, but you can't get to a 4 to a 5 on volume. You need severity.
Well, and the other thing now is how many providers are looking at that, and it really drives me crazy. The prescription drug management. Do you know how many podcasts I've done just on that topic? How many educational things where I'm like saying, refill prescriptions, that's not a level 4. Management means, yes, there has to be some kind of RX authority, but you have to explain what are the outcomes and the connection to the problem you're addressing, to that treatment plan that includes the medication and the management of that. And
And
so I'm not seeing that in the record, and they're trying to get to level 4s.
and that's the low hanging fruit, right? That should be the
It
easy thing
is.
to fix.
It's the easiest one. Yeah, it is. But I just think the definition sometimes is missed. It's like, no, you're dealing with today. You mentioned about, well, I'm going to bill a 4 today because they missed giving me that money before. It reminds me of baseball I was watching this weekend. We had some terrible umpires. I don't care what your team is. They were just terrible this weekend. It must have been something in the water. But I'm just like, oh, well, they gave them a strike on that one, which clearly wasn't a strike because they missed it before. It doesn't work that way in healthcare. So you have to be careful
There are
with
no
that.
makeup
Did
calls.
There's no makeup. Yeah.
did anybody happen to see the nutty Dodgers Giants play the other
No, I'm
day?
not
I did
watching
see a
Dodgers right
highlight of
now
that.
because
Yeah.
they're evil.
Yep. All right, Paul, I know you had something that you wanted to say. Go ahead, buddy.
Yeah. Well, I had 6 doctors in my family, and I can tell you that I never spent more than 30 minutes with any of them. And I'd like to include my late Uncle Alfred, who used to go around criticizing people for eating dessert. It worked for him because he lived to be 99 years old. But and that's the lighthearted part of that conversation. But honestly, in 2021, when the E&M guidelines were changed, it's no longer, I spend half the encounter talking to the patient, so I get a level 4 or level 5 or something of that nature. Time is a lot more granular now. You've got to identify those individual activities more so what you did away from the patient than you did with the patient.
Yeah, what
Because
specifically transpired
yeah,
during the course of the day in which you had to
yeah,
face-to-face encounter with the
and
patient?
and
Well,
spell it out. And these
yeah,
catch-all paragraphs that say it included blah
right.
blah 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 blah. Blah. Well, did it, or is that just something that
It's
you're
a
just
canned
Is
plastering
statement.
it a
to
macro?
to
Exactly.
documentation just to
That's right.
cover yourself?
Well, what did I send you guys not too long ago where it said it was buried in the splitter shared visits and it was like a D element and it said, oh, for time visits, we're going to be scrutinizing those even closer now. And I'm like, where did you put this in this update? This is for splitter shared visits. This had nothing to do with E&M, but they related it to E&M services when it came to time. It was just like,
Oh,
okay.
these notes I saw last week that I was talking about before, these notes had time in them as well. And I kind of threw up my hands, and I have to talk to the client a little bit later today. And I was like, look, I can't justify the time because I literally have no idea what they did. I
I
couldn't
have
tell you what meds they're on. I couldn't tell you how their conditions are on an individual basis.
Scott, I've got doctors that say the time should start when the patient walks in the office because they're paying the expense for the office space. I'm like, where did you
Yeah,
get that from? Give me a cited
yeah.
cited works for that.
But
They said, and the timestamp. I mean, I guess I would not as shaking my head as hard if they would have said from the time the patient walks in the room. But I said you have to be in there, and they said, well, there's a timestamp on our EMR, so it says what time the patient walks in the room and what time they're checked out. I'm like, okay, but we're looking to inter-service time. When were you in there? And then also, then the ancillary staff is doing some of the history, some of the exam components. And I said, it says clearly in the AMA rules, you can't use that. It's what you do. And they said, well, they mean me and who works under me. I'm like, no, they don't mean that. Where are you getting this?
yeah,
So some of these
no,
assumptions that are being made, and then,
yeah.
or then they do a procedure and they don't carve out that time of the procedure within the notes. So then I'm guessing, I'm like, well, I think it took you 30 minutes for that procedure. So you only spent 10.
Yeah.
And they're just like,
But
what?
then
Yeah.
we're challenged, Terry. Then we're
Yeah.
challenged. Well, yes,
Yeah.
here's the guideline, here's the regulation, but I don't think that's what it meant for me.
Right. And then when I try to carve
Oh,
out a time for how long it took them to do a minor procedure because they didn't put it in there, 1 minute they're saying, well, it takes me a long time to do those procedures. And so I should get credit for that. And then you carve out that time. They're like, well, I didn't spend that much time. I should get the whole time for the visit. And my face planning days are really
Yeah.
big right now.
Well, the main idea here, I mean, uh, we've always had some kind of push-pull between science and regulation, and physicians need to understand that from the science of medicine standpoint, your medical documentation is going to be with that patient, honestly, for the rest of their lives, particularly in an electronic situation. It's not busy work. I mean, you have to really paint a clear clinical picture of why that patient was there today. It's not just a matter of these are the new rules, so now I can do the bare minimum. That's not it at all.
Yeah.
You have to credit yourself for that work by making it very clear what medically did you do for that patient that day.
Excellent points. All right. Well, that's going to bring us to the end of another Compliance Guy Monday Coding and Compliance Roundtable. As always, I want to thank Christine, Scott, Terry, and Paul. We missed Stephanie this week, but I know she'll be back with us again next week. Thanks to each of you for being here today, and to each and every single one of you who continuously tunes in, logs on, and hangs out with us. Thank y'all so much. Terry and I are going to be back tomorrow with a brand new hashtag Terry Tuesday. I have a feeling we're going to build on some of the medical necessity stuff that we've talked about here today, and I'm looking forward to that. All right, later this week, we're going to have a great podcast with two former OIG professionals, one who was a special agent and another one who was an attorney with the Office of Counsel to the Inspector General. So I have lots of questions for these two individuals, and namely, why during your tenure did you make everybody's lives so miserable? No, just kidding. It's going to be a great episode. I'm excited to have them both on. We'll feed you more information as the event comes about on Thursday. So until then, remember, be good to yourself, but more importantly, y'all be good to each other. Take care.